everyone, today we'll talk about medical management of tubal ectopic pregnancy with methotrexate. All of us know ectopic pregnancy is the implantation of the blastocyst anywhere outside the endometrial cavity, and the fallopian tubes are the commonest site. We have option of surgical and medical management, but in this video we'll discuss only the medical management. The most important drug used in medical management is methotrexate, which is an antimetabolite or a folic acid antagonist. It binds to dihydrofolate reductase and prevents the conversion of dihydrofolate into tetrahydrofolate, which is an active form of folic acid and is required for DNA, RNA and protein synthesis, very important for rapidly proliferating cells. With a block in this chain, the rapidly proliferating cells of trophoblasts are affected, which helps in the medical management of ectopic, and its effect on the rapidly proliferating cells of GI mucosa, bone marrow and respiratory epithelium leads to the side effects of hepato and myelotoxicity. The drug is excreted by renal clearance. Regarding the patient selection, there's a long checklist. First of all, the success predictors are low serum beta HCG, small sized ectopic and absent fetal cardiac activity. The disqualifying criteria are ruptured fallopian tube or drug contraindications. We need a close access to emergency care, and surveillance lab tests should be easily available. These include renal function test, which is important for renal clearance of the drug, liver function test and complete blood count to monitor hepato and myelotoxicity, and obviously serum beta HCG monitoring is important to assess the results of methotrexate. All these tests are needed as a baseline and before repeated dosage of methotrexate and in follow-up. That's why they are called surveillance lab tests. We get a blood type and RH of the patient done. Besides that, you counsel the patient to avoid aggravating factors like folic acid supplements, NSAIDs, alcohol, sunlight and sexual activity. Counseling about methotrexate teratogenicity, embryopathy and excretion in breast milk are important. The contraindications henceforth are listed here. Once you've decided to give methotrexate, you have two options, a single dose and a multi-dose regime, both of which use intramuscular methotrexate. Single dose regime is given as per the body surface area of the patient in a dosage of 50 mg per meter square given on day 1. Serum beta HCG done on day 1, 4 and 7. Between 4 and 7, there should be a minimum decline of 15% in the level of beta HCG. If it does not happen, then you give a second dose on day 7, which becomes a new day 1. After repeating the baseline investigations, you repeat day 147 again. If the decline is satisfactory and above 15%, then you put the patient on a weekly follow-up of beta HCG, and a 15% decline is required every week till beta HCG becomes undetectable. And if in any week you find that the decline is less than 15%, you give a second dose there, and that particular day becomes the new day 1 with the repeat protocol. Up to 2 dosage are given maximum in this protocol. Coming on to multi-dose regimes, there you have an option of giving up to 4 dosage of methotrexate on 1, 3, 5 and 7th day of therapy. In that case, it is alternated with leucovorin on day 2, 4, 6, 8, which is a folinic acid, and it blunts methotrexate toxicity. Before deciding how many doses to be given, you get a serum beta HCG done every 48 hours. As for example, you give methotrexate in 1 mg per kg body weight dose on day 1, leucovorin 0.1 mg per kg on day 2. Then you get a beta HCG done. If it is satisfactory, then you don't go for further dosage. If it is not satisfactory, then you give another pair of methotrexate and leucovorin, wherein methotrexate on day 3 and leucovorin for day 4, and you continue till 4 dosage or serum beta HCG level fall more than 15% in 48 hours, wherein you put the patient on weekly follow-up thereafter. The side effects expected are listed here. And regarding the choice of regime, both the regimes have their own advantages, but the single dose is simple, less expensive and needs less intensive monitoring. Multi-dose claims to be giving higher success rate. Overall, the resolution rates with methotrexate in ectopic pregnancy are 90%. Thank you.